Maternal Sirolimus therapy for fetal cardiac rhabdomyomas. Definition: Cardiac rhabdomyomas were diagnosed in a fetus at 21 weeks of gestation by means of fetal echocardiography. The majority of these tumors are classified as being and include rhabdomyomas, teratomas, fibromas, gyromyomas, and myxomas. The most common among these tumors are rhabdomyomas. Rhabdomyomas are derived from embryonal. Myeloblasts are the composed of myocytes, with large vacuoles and considerable quantity of glycogen, often referred to as spider cells.
Maternal Sirolimus therapy for fetal cardiac rhabdomyomas. Via search.nejm.org web link. Figure, findings on echocardiography before and after birth. Cardiac rhabdomyoma is the most common fetal cardiac tumor. We report a case of progressively obstructive fetal cardiac rhabdomyomas with regression in utero during treatment of the mother with an oral mechanistic target of rapamycin (mTOR) inhibitor. Cardiac rhabdomyomas were diagnosed in a fetus at 21 weeks of gestation by means of fetal echocardiography. The probable diagnosis of tuberous sclerosis complex was made by association. Progressive tumor growth and bilateral outflow tract obstruction were noted at 30 weeks of gestation, Figure 1a, with supraventricular tachycardia and impending hydrops fetalis. Considerations of the multidisciplinary team included extensive surgical debulking, premature delivery with extracorporeal membrane oxygenation, and the use of prostaglandin. Each of these options was limited by high risk and a low probability of success. Oral sirolimus was initiated in the mother with a target maternal serum trough level of 10 to 15 nanograms per milliliter, with subsequent tumor regression in utero, Figure 1b. Delivery occurred at 36 weeks of gestation. The cord blood sirolimus level was 11.3 nanograms per milliliter, and the concurrent level in the mother was 6.9 nanograms per milliliter. After birth, the tumor progressed while the infant was not receiving therapy. Sirolimus was initiated in the infant at 2 months of age, with a target trough level of 10 to 15 nanograms per milliliter. Tumor regression was again noted after 3 weeks. A similar pattern occurred when sirolimus was discontinued at 4.5 months of age, with tumor progression and then repeat regression after restarting therapy.
Application in nursing. The patient underwent invasive testing for genetic analysis for aneuploidy and tuberous sclerosis.
Brain imaging revealed no lesions. At 9 months of follow-up, no clinical seizures or epileptiform activity were noted on electroencephalography, and appropriate somatic growth and development had occurred. Genetic testing revealed a pathogenic variant, circa 1781 delt, P.val 594 glyphs 35, in TSC1, which confirmed the diagnosis of tuberous sclerosis complex. See the supplementary appendix, available with the full text of this letter at nejm.org. In this case, we used oral sirolimus in a mother to treat fetal cardiac rhabdomyomas non-invasively. The choice of therapy was based on a high likelihood of concurrent tuberous sclerosis complex 1 and reports of success after birth with mTOR inhibitors for treatment of cardiac rhabdomyoma in infants with tuberous sclerosis complex. 2,3 The dose of sirolimus used in the mother was based on accepted guidelines for solid organ transplantation in adults. 4 It is possible that the primary form of transplacental transfer was through a unidirectional enzyme transporter mechanism. See the supplementary appendix. Regression of tumors correlated with administration of sirolimus both prenatally and postnatally in a fetus with a high risk of death. 5. At 9 months of follow-up, the infant continued to receive sirolimus with appropriate somatic growth and development. Further study is required to determine the efficacy, safety, and most appropriate dosing of oral sirolimus in mothers for the treatment of fetal cardiac rhabdomyoma. Benjamin T. Barnes, M.D. Johns Hopkins University, Baltimore, M.D. Barnes 17 at me.edu. David Procaccini, Farm.d. Jude Greno, M.D. Karen Blakemore, M.D. Johns Hopkins Hospital, Baltimore, M.D. Priya Sikar, M.D. Johns Hopkins University, Baltimore, M.D. Caitlin G. Sagasser, M.S. Angie Siegelin, M.D. Johns Hopkins Hospital, Baltimore, M.D. Lazia Gower, M.D. Johns Hopkins University, Baltimore, M.D.
Pros and cons. Disadvantage. Hypersensitive reactions have been associated with the administration of Sirolimus, including anaphylaxis, angioedemas, exfoliative dermatitis, and vasculitis. Advanced Sirolimus was initiated at 30 weeks, which improved in tumor size and cardiac function until delivery at 36 weeks of fetal bradycardia.
Welcome to this section on the congenital heart diseases, risk factors, predictors, and associated diseases. I'm TK Lau from Hong Kong. My co-chair is Dr. Hernandez Angeli from the United States. And to start with this section, we'll have Dr. Professor Rabi Chawi doing a live scan on the first trimester echocardiography. Rabi, are you ready?
Yes, I'm ready. So the lady is pregnant. The length of the fetus here is 75 millimeter, which is the good time to perform the nuchal scan. And I will be now, I was asked to do the fetal heart, and I will generally, I will use it like this to show the short kind of cross-section of the apothorax, but in general I will use rather a preset for the cardiac scan like this, and adjust, increase slightly the contrast and have the image less colored, and then you can do what we do in general, the second trimester approach. Occasionally, you don't know why, on the abdomen here you have some shadowing. You can turn the transducer to get more better view without the shadowing of the ribs here. And you see here clearly, starting by the upper abdomen, the stomach, and here the pulsation of the abdominal vessels. Then basal approach to the four-chamber view with two AV valves with the septum, and then by tilting slightly cranially, we should be able to see the great vessel. But if you wait a little bit, you will see the baby will turn anyway at the stage around. This is the ideal plane I use to check the great vessels, because you would see on color Doppler how the aorta will be arising and the three-vessel trachea view will be seen. So now, if the baby is turning like this, I will wait which position the baby will agree to do, and I'm now lucky that it turned this way. And by adding color Doppler here, in general, I use the color Doppler and the HD flow, the high definition flow. And now I'm at the velocity of 36 centimeters. I will go a little bit less. And occasionally I will play rather with the power of the machine, with the output, than with the velocities. Now I can have here, show you, this is the ascending aorta with color Doppler. And this is the filling of both chambers. That means at this stage I can tell you we have no single ventricle, no hypoplastic left or right heart, no tricuspid mitral atresia, And the ascending aorta is well seen, but at this stage I will not be sure in saying that it's not an overriding by this image alone. I will rely rather on the three-vessel view to see if the size of the vessels and the size of the aorta in relation to the pulmonary artery are normal. But this is life. In January, I will be more rapid because I will not tell stories during the scan. I will have used the first image to get this view, but we'll see now. And if the fetus is not cooperating, I will hit a little bit this way, or I let occasionally the woman cough, and then until the baby turns. Now you see here from the other view. Okay, let's go with another technique, which is the HD flow. And now, give me a second. I will. Let's magnify the image. What I want to do now, I'm checking to get the three-vessel and the trachea view. And by this oblique view here, I can at least recognize that I have two patent great vessels. This is the aorta, and this is lower plane, the pulmonary artery. But I'm sure I will get them in a better way. And this is the plane where, well, if the baby is lying like this, I will take it to see them in red, the three-vessel view. Okay. So now this is the nice filling of the chambers. And I will document this image to have it seen, and then I go for the three-vessel trachea view. And in this plane, I will, I'm sure it's a very nice picture I want to show you here. And then aorta, pulmonary artery, here is approximately the trachea. And by going lower with the peak velocities, and increasing the power and reducing the filter, we may see behind the trachea or in front of the trachea if there is the subclavian artery, which is in this case, you can, so give me a second here. You can see here, this is the subclavian in front of the trachea. And if the fetus is in such a good position, you see here we can even recognize it on 2D. There is a plane I like to do. I'll show you in a second how it is done. Because in general, we are scanning from at the level of the heart and getting to the vessels, but try to scan from the abdomen, the heart. I need a true torso-posterior position. I'll add the color. I have the good preset prepared. And if I scan like this with a really extremely oblique plane, then you can recognize the crossing of the vessels. I can't see them now at this stage. Another point which is also important is to see the cardiac axis. As you have seen here, it is a normal axis with no deviation, and we'll have here a talk presented by Elena Sinkovskaya on the abnormal cardiac axis and many cardiac abnormalities. So please turn around. So I prefer occasionally when I have good scanning conditions to try with a linear probe. I will switch now to see if I can, if the baby is in good position for linear probe, it would be ideal. This is a very thin probe with a very thin footprint. This is the general view, and I prefer to use it with a linear approach. Then you can here recognize the pattern of grayscale. The kidneys can be well seen, and if the baby turns for a cardiac scan, I switch the cardiac, I make the image a little bit darker and more contrasty.
Issues apply in Ecuador. Rhabdomyomas are the most frequent and effective heart tumors. 60 to 86% of fetal heart tumors. In Ecuador, this type of medication has been proposed since 2005, but it has multiple uses for diabetes, arthritis, anemia, leukemia.
And you can see very nicely the structures here, the left, the right ventricle. And by adding the color, you have here the ascending aorta and the three-vessel trachea view. And you can here with this, you see the difference. With this one, you see even the trachea a little bit exaggerated because of the calculation of image, but so, and then I'm waiting that the baby gets in a better position. You can do the same by having the HD flow here. Aortic arc, ductal arc. And again, the same procedure by, if you lower the velocities, you will see pretty nice. If the baby is not moving a lot, you can play a little bit with the color until you get the best preset. This is, for example, ideal plane. And for me, what I tell in meetings, I need in general two typical planes. I need a four-chamber view well seen, like a lateral one, where I see the continuity, and I would need, in addition, the color one of the four-chamber view, which is the one I showed before, and then the three-vessel trachea view, which are, let's say, these three are mandatory in addition to the subclavian. I will go back to the other probe, and then
Ravi,
TK on Edgar. If you have questions, please go ahead.
Ravi, can you hear me, Ravi? Ravi,
Yes.
just a question. Do you have a recommendation when to use normal color and when to use high definition color?
Yeah, this is a good question. No, I don't have. I don't have typical recommendation. It depends on the way I am. I have the, let's say, differentiation of image. I prefer for AV valves to use the color Doppler because I can better see the tricuspid regurg if I have some. But for the crossing of the vessels and the smooth transition, you can have them better with the color Doppler like this. Yeah. So you see here how so, and not getting the ideal plane I want to, but I will try to take a stick. Roland, is it okay like this? Yeah. Let's try to have a rapid stick. Oops, jumping. Yeah. There was some artifacts here because the baby jumped. So let's say 10 seconds is too much. Let's have 7 seconds and a half. Give me 1 second and I will do it another one, and then.
Can I have another question?
Yeah, go ahead.
Ravi? Yes, for a normal guy like me, which will be the normal planes that we have to get at this stage? I mean,
Yeah, I told you. Who is asking the question?
Edgar.
Edgar, you are not a normal guy.
Thank you.
Edgar, you are the expert. But a normal guy like...
Like me.
like you, if you want to be a normal, I would recommend you to, as I told before, this is the
Beautiful.
the 3D of the heart. We'll need to cut. I told you I will recommend always the 4-chamber view on 2D, the 4-chamber view on color, and the 3-vessel trachea view. And this should be, for me at least, let's say, the standard plane we are getting. And you see here with the 3D that we are able to recognize the chambers, the pulmonary artery, and the aorta. I know that I couldn't get it better if I had the fetus in better position. So again, this is, let's see, one plane, the 4-chamber view. Let me magnify. The other plane could be with color for the 4-chamber view. I can't get it now because the baby is not turning, but what I showed you before. And then the 3-vessel and trachea view. So with the 3-vessel and trachea view, you can at least rule out almost all conotruncal anomalies from right aortic arc, interrupted aortic arc, severe coarctation by the combination of the size of the ventricles and the size of the great vessels. Transposition, you will see only one large vessel instead of the V sign. Common trunk, you hardly see 2 vessels in the 3-vessel trachea view. A double outlet ventricle may be recognized, but the vessel position, they are rarely could be seen in the typical plane. And the only thing you cannot really rule out in early gestation is a tetralogy, the mild one, and some VSTs. And but let's say in general, if you look at the typical pitfalls, it's more limitation due to scanning conditions rather than let's see, because you cannot see, because the image was normal and it was not. So this is the baby here.
Ravi, another question. Do you suggest transvaginal ultrasound for fetal echocardiography at this stage?
So the question is if I suggest vaginal ultrasound. Now it depends. If this was a screening condition, it is enough for me. If there is a very high risk, I may have decided to use it transvaginally, or in less specific cardiac anomalies in history. Let's assume abnormal lung veins. I will try to see them transvaginally. But let's say if there was a history of heterotaxy by showing the stomach on the same side as the heart, the normal heart at this stage, and I will add here that the IVC inferior vena cava can be seen, then it may be enough at this. Now we are between 13 and 14 weeks gestation. If I'm scanning a fetus with less than 6 centimeter CRL, the likelihood of getting transvaginal, if the image is not very good, is great. This is why, in general, below 6 centimeters, I guess more than half will go for transvaginal scan. More than 6.5 and more, it's unlikely to go vaginal unless there is an history or an indication. So I think...
Ravi, just 2 questions more. So,
yeah, please.
In the first trimester, since when can we have this kind of quality in ultrasound? I mean, after 11 weeks, after 12 weeks, 13 weeks?
It's a good question because this image quality, you can get it even better if you go transvaginal at, let's say, 12 weeks, 11, 12 weeks, but you need also some expertise because you need to know how to manipulate the child, the fetus to term. If you have a fetus like this now standing, there is no chance to do. What I do in these cases is I check what is else seen here and where is the position of the cervix. This is the cervix. That means if you go transvaginal here, you will see the back of the fetus. But ideally is if you see the cervix here and the fetus is lying transversal in the lower plane. This is, for example, now could be good for the heart because you will be scanning roughly from here and the heart is showing back. This would be ideal because this is the cervix here. You will arrive with the transducer here and will be having the heart just in front of you.
Conclusion. As 3 previous reports showed, we demonstrated that maternal Sirolimus decreased Rhabdomyomas growth in the fetus. The case agrees with the previous report that Sirolimus improves cardiac function. This report demonstrated that Sirolimus may be helpful for the revision of fetal cardiac rhabdomyomas.
Or your scan. This would be ideal. In general, up to 12 weeks and more, the fetuses are not lying horizontal, but they are standing like this, and you don't see them easily. And let's say I would recommend 11, 12 weeks to do abdominal, the nuchal, nasal bone, and the whole things you can do, and you can implement or add the heart. So, and this is the plane I use if I have dorsal anterior for ductus venosus here at this stage. Now the heart. Okay.
We have 5 more minutes, so is any question for the audience for Dr. Shawi?
Even if in this position, I will try, for example, if I have a dorsal anterior, I will try from this plane to get a feeling of the chambers.
Shawi, we have a question from the audience. It's
Dr.
okay?
Chowie, it's Dr. Pretorius from San Diego.
Hi, Dolores. Yeah.
The AIUM has that we're not supposed to use color. Do
Yeah.
you, in your mind, it's clear that if we're going to do first trimester hearts, we have to use color?
Yeah.
So do you, in your mind, have anything that you're doing? Are you watching your TI, your MIs? I've been watching them the whole time you've been scanning. It hasn't changed very much between your, it's been mostly 0.3 and 0.2 for your TIs, and your MIs have been 0.7 and 0.8. It hasn't changed much for power versus high definition.
No.
But do you try to limit your color to a certain number of minutes, or
Yeah.
do you?
Yes, I do this because I have a special preset for the heart in the early gestation. And as I told you before, to get a better color, I'm using a less output. You know, I'm using, in general, I'm between 60 and 80 because the image is even better if I go for low PRF and more gain but less power. Because if occasionally if I have for great vessels, I will go probably for this, and then I will add a lot of energy. Now we are still at level 0.4, but now I have 100%. I don't need this because I can get the same picture without getting to 45 centimeters per second by lowering my peak velocity and then lowering the gain. So I wanted to say what I do, Dolores, honestly, I have a good preset and I don't spend more than 1 minute, even less for the heart. If I have a good scanning condition, I need the 4-chamber view like this now, even a bad position now, the 4-chamber view like this here, and the 3-vessel trachea view as I showed you, and then in a way I'm done because you are doing screening. Of course, if there is a history, that things change, and this is why there is always a kind of the yield of detection. If you are scanning a regular patient, you have out of 1,000 2 complex cardiac malformations. If you are scanning a patient with the history of a previous child, you have 2%, which is 20 per 1,000. And you cannot do accurately the same observation on a screening basis for both. One is a high risk and you will scan it with other eyes, and one is a routine and you will do a routine. Of course, in the first group of a risk of low risk, you may miss occasionally something, but you should not be missing at this stage, let's say the situs or single ventricle or severe malformations of the great vessels where one is missing, you know, but